start. Um, it's an honor to be here and good to see all of you. We are going to have a very fantastic time with the Afrofusion. Please do take a moment to go see what is there. There are quite a few. One minute. Yeah. Are we good to go? Experience in Cameroon Ministry of Health and Sans Frontier. Also has an MSc in International Health and Tropical Medicine from Oxford University, and currently
share my work with you. And this is a theme on the conference was more of God health. So I have to warn you, this is something very close to work to God health, but it has to do with travel. Master's degree, I did some work using the case study of Thailand, where I explored how we can use mathematical modeling to predict the effects of well. Yeah, this is just an outline of the processes involved. So yeah, once upon a time, have this pandemic which came up. One of, I think, the very first country to experience COVID outside China, and we also had very varying degrees of stringency in terms of applying. One of the rationales for undertaking this study was there are several parameters which would influence the rate of transmissibility of COVID. An infectious person comes in contact with a susceptible person. So someone who is susceptible is someone who doesn't have the virus yet, but can eventually get the virus. So they're either not immune or haven't had the infectiousness. And that was a very important element that I considered when designing the model, because not everyone who is in the incubation phase, just setting the background of some of the parameters I took. Next slide. So this is just a bit of the global of the numbers at the time when I was undertaking this study. That was like in May 2020, and we see that Thailand also is a very touristic country. It's a country which is whose GDP is heavily dependent on the tourism component of it. And by the site data showed that there was a massive drop in travel related income. Hence, the government was now trying to mediate these economic losses by bringing down the restrictions on travel. So when there was a lot of panic and there was uncertainty about controlling the situation, so many countries were implementing this. So the WHO was not very confident about this measure, and they thought, more chances or conditions than just giving the blanket closures, and it wasn't also very objectively implemented across different governments. Next point. Then we have selective and midterms where governments were allowing travelers to come in depending on the situation of the origin countries. If they had high prevalence or low prevalence, and we had things like the traffic system operating green, yellow, red countries, and that was very classic in the UK, for instance. And also the history of vaccination and all that. Screening for symptoms, so temperature checks at the borders, which was also proven to be very ineffective. That's again for the reason of incubation versus infectiousness. So one can be actively shedding the virus, but because they have not yet gone through the incubation period, they are infectious but not having symptoms. So using symptoms was not going to be helpful. Vaccine requirements, which I explored in my model and testing. So yeah, testing pre-departure upon arrival, or double testing like pre-departure and after arrival. Quarantine mandates, so mandating the travelers to be quarantined for so and so period. Also depending on their situation, were they vaccinated, you quarantine for so number of days and all that. This is just a reminder. I know we are very conversant of all of these. Next point. So like again, just to illustrate the situation of Thailand, I took these countries in Southeast Asia which had a similar epidemiological pattern of the COVID-19. So they had the similar periods of their peaks of incidents. And then I took this from the Lebanese School of Government Policy Review website. So they were comparing the degree of stringency of the travel restrictions for these countries, and Thailand was like the lowest. So at that point, they had relaxed their measures most compared to the others. And next point. So this is just maybe like an icebreaker at this point. What is mathematical modeling? It's true we talk about prediction, but it's not what we can see. Next slide. I wish I had more of our African ways of showing magic and voodoo, but so it's not about divining or telling the future. Next. Yeah, it's not number theory. It's not all of this. So it's actually studying patterns of a situation and trying to replicate it using an equation. And if we are able to have sufficient data, we can then represent a real situation in a mathematical equation and determine different outcomes if we take into consideration different conditions. Please one step back. So again, the concept of susceptible, exposed, infectious, recover. So this is the model I did. So it's called the disease transmission dynamic model. And I had to carry out extensive literature review to determine the prevalence of people who were susceptible or exposed or infectious or recovered, also depending on vaccination history and all that, to be able to have numbers that would mimic at least the reality. To have a good mathematical model, you have to have a lot of conditions you take into consideration, and so the more conditions or the more you're able to relax your assumptions, the stronger your model will be. So so the beta here is the rate at which individuals who are susceptible become exposed. So the rate of mixing of susceptible people with infectious people. And then this symbol which I chose was the rate from which they become the rate of movement from the exposed to the infectious group, and then the last symbol, the rate of infectious people becoming recovered. So becoming recovered in this sense would be becoming immune to further infection. Next. So what were my objectives? So I was going to develop my assumptions and to also find out my initial conditions and parameters. And I was going to now build a model based with these various equations to take the parameters into consideration. And then I was going to have my results after running the model based on those primary parameters I found. So just like I alluded to before, I did a lot of literature review, and with these various sources from the PI government website, from the WHO, from the Lebanese School of Government Policy Review website. And then last year, same time, I wasn't at the gala, and I missed it sorely because I was in Thailand having discussions with stakeholders at the Ministry of Health just to explore the reasons for which they chose the policies at the time and what were their plans for evolving those policies. So I had to review those policies and also try to do some kind of engagement with them to see what would be more resourceful for them to explore if I want to test, the effects of double testing or quarantine. Is this something you would like to implement so that it's also useful for them to implement in the future? And keep going. Let's stop there. One more. So these are the scenarios that I came up with. We have 7 scenarios here, with the most stringent one being the 7th, and I try to represent it in terms of sizes of a funnel, where the most stringent one, like, it's like the smallest funnel that would allow very few infectious people to get into that. So actually, what I'm trying to look at, or what I was trying to look at is at the end of the travel journey, how many infectious people are released in the community. So if the different parameters or like if the different scenarios can show me how many infectious people are released, and I can tell this is more effective than the other, because the incidence will be determined by the number of people who can continue spreading from wherever they're coming. No, please go back. So I just wanted to pay attention to the key elements of the scenario. So we have testing upon arrival, we have vaccine requirements, we have quarantine. And then I had to combine those at different levels to determine their strength. And then this is just an overview of how I build up the different equations. And based on the literature review, I had to split the groups of travelers. So if I assume that the travel rate is 100,000 per day, and I just took that from the Thai website, it means by the time we go through the 14 periods, like from the 2 weeks when they've applied for their visa to the 1 day when they have traveled, when they've taken the flight, to when they eventually either get quarantined or get released, we have this number of people in the different compartments. Next slide. This is again just a model. I won't bore you with this. Next slide. And this is just a snapshot of the data frame from one of the scenarios I was testing. Next. So we can see here a comparison of 2 of such scenarios, where scenario 5, which was looking at screening, that's testing at the border with passengers having been vaccinated, and then scenario 7, which was looking at a combination of travelers having been vaccinated, testing at the border, and quarantine. So we can see the difference in terms of the number of infectious individuals who will be released in the community eventually. Next. And again, this is just a simplified version of the graphics. So again, this 7th scenario proves more effective. It's also very stringent. Now the question from the policymakers: how sustainable is this in our setting? Can we afford it to to let people go through all these restrictions? It would then reduce again the travel rates. Or this one says just do nothing, but in the end you have almost everybody coming in again infectious. So we kind of find some middle ground which they can then utilize depending on the current situation. And yeah, so that's what the work did. And I just want to give acknowledgement to my supervisors at the time. And next slide. Yeah, thanks very much. Sorry that it took too long. If you have any questions, I'm happy to take them. Otherwise,
have you got any questions at the moment for Dr. Dino? I thought that was a very beautiful.
I think I can't get my head around the initial assumption. Because I think all of it goes about the assumption that you did initially before you have to study. Am I correct?
yes, sure.
And what I don't know, how did they, when they put people in the community, because the models shows that people who are vaccinated, we checked at the border and so on. How did they know now the incidence of that particular group?
Right, thanks for the question. So it wasn't looking at a particular group, it was looking at an entry rate. So the rate at which people are entering the country, and we capped it at the rate of 100,000 per day. So which means at the end of the transit of those 100,000 people, what proportion of them would be infectious and released into the community, and how would that contribute now to the total incidence? And the incidence, of course, we were able to obtain it as the daily count of new cases coming up. So it was more of a rate than a snapshot of total number of people having traveled into the country and spread the virus, if that makes sense. So it was more of a rate. So we capped the rate from this, and this was taken at an average, because of course not every day you have 100,000 people. But we took an average of a month's travel data and averaged the 100,000 people who would come to the country. And then of that 100,000 people, if we say they should have been vaccinated, they should be double tested, they should be quarantined for 5, for 7, for 10 days, because all of those details had to be taken into account to make the model strong. What proportion of them, when released into the community, will still be infectious? And then we study how it relates to the incidence. Like we predict how it will influence the daily incidence of the virus.
I think that is interesting. I remember you telling me that you went to Thailand to do part of your thesis, and what you've presented there looks like an interesting piece of information. What I am actually keen, maybe I missed it during the presentation, is the impact of relaxing the immigration or the entry restrictions on the economy of the country. Because maybe you said it and I missed it. The different levels of stringency depended on how it impacted on the economy of various countries.
Yes.
And different countries had their own levels. And despite all the spin that we had on TV, economy was the backbone of decision making. Did you manage to get perception of how those changes affected the economy of Thailand relative to Singapore, for example, or to Vietnam also?
Excellent question. So the economic impact was actually out of the scope of my study. I was just looking at the epidemiological impact. So the effects on incidence risk reduction. And then it will be maybe a follow-up study, to look at the economic evaluation of that. And that will have to take into consideration a lot of other aspects. But I was just, so where I ended was, at the end of this travel set, this number of people are going to be raised into community infectious, and it's going to speed up the incidence by so and so. And I didn't carry on to look at how would it then impact the economy in terms of, reducing workforce because people are sick, or the economic costs of letting them quarantine for 10 days instead of 7, So actually, it wasn't exploring the economic impact, it was exploring the epidemiological effect of the infection.
Thank you very much. A round of applause for the I think that was quite fascinating. I think it just shows that COVID wasn't just a medical issue or a health issue. It was both a political and economic issue as well. Now we move on. We've got our second speaker. Now, if she'll be talking about diet in inflammatory bowel disease, as we know, or some of us who have worked across continents and across countries, the prevalence of inflammatory bowel disease does vary with where you are. Is that related to the diet? Is it a cause or a cure? Again, I'm not expert in that, so I'll let Dr. Jibinzo tell us a bit more about that. Now, she is a pediatric specialist trainee in the East Midlands. As we know, she's been starting her subspecialty training in pediatric gastroenterology and hepatology in Birmingham Children's Hospital. She's also somebody with a master's in public health nutrition from Southampton University. And so I'm sure she will be able to give us a bit more information to upgrade our knowledge on inflammatory bowel diseases in children. Thank you to Control for accepting to have a word today.
Good morning, everybody. Do I need to use the...
Good morning, everybody. It's my pleasure to be here again today. I was here last year and I was here this year. I promise I'm not going to be here next year. Anyway, so Uncle Val said he's not the, Dr. Val Ngoa said, he said he's not the expert. I'm not the expert either. I'm very novice, but Prof is probably going to.
It's on here, so you don't have to be holding it.
Thank you. Thank you. I couldn't find it.
Only my name can place it. They're not.
There you go.
Thank you. So, yeah, well, I was saying that I'm not quite the expert yet, but, you know, and so Prof is here. He's going to point out or, you know, help us with any clarifications and questions. So basically, I was asked to give a talk. It's an IBD day, sorry, a bowel day, and we're talking about gut health and all of that. And so I thought, you know, IBD would be a good one because it's quite common. I'm pediatrician, but it cuts across both pediatric and adults. And I thought, you know, it would be a good one to talk about. So next slide, please. So we'll go through this outline. Next slide, please. So first, looking at IBD, what it is, just a refresher. I'm sure we all know, we're all doctors, or most of us, and we all know what IBD is all about. Next slide, please. So IBD basically is an idiopathic disease. It's described as idiopathic autoimmune inflammatory condition that causes a chronic, so it's chronic, it causes chronic inflammation. It's characterized by relapsing and remitting kind of course. So that simply means that you have inflammation of the gut, and you can come in flares, and then you have the remission phase where you're kind of stable clinically, or look clinically all right, your biochemical parameters are stable, and you know, no active inflammation going on. That's basically IBD. So it's lifelong, and it's really described as a disease of the northern hemisphere, except Australia, which is kind of the exception down south, which I'll show you later. But then there's also evidence that the incidence is rising. Incidence and prevalence is rising in certain countries that are getting more westernized. For example, Asia is a very good one. Next slide, next please. And it's relatively common. So in the UK, it affects almost 1% of the population. I think that's quite common. So, and just worth noting that over the years, the incidence has increased quite significantly. It's also got quite a, especially in children, and I don't know about adults, but in children, especially in the recent years since COVID, we've seen quite a lot of IBD. We've had sometimes related to COVID, but that's something that's really still being looked at. Next, please. So there are two main types of IBD. There's an intermediary, but basically there's Crohn's disease and there's ulcerative colitis. So Crohn's is, can affect all parts of the gut, whereas ulcerative colitis, as the name implies, is an inflammation of the colon. So as you can see from here, so ulcerative colitis tends to be limited to the large colon. It's the inflammation of the colon, like I said, whereas Crohn's disease can affect anywhere in the digestive tract, tends to be more systemic, tends to present with more systemic unwell, so that weight loss, diarrhea, and whereas ulcerative colitis tends to present more with bleeding. But sometimes it's difficult to really tell whether it's one or the other, and sometimes you have an undetermined type of condition, but generally you have these two. And this kind of manifests, or is the manifestation of the histological changes. There's also a significant difference in the histological findings. Next, please. So with ulcerative colitis, you tend to have more pseudopolyps, kind of loss of hyalostria. It's kind of a continuous inflammation along the lining, and tends to be more left-sided, kind of an ascending disease, compared to Crohn's disease, which, like I said, can affect anywhere, but when it affects the colon, tends to be more right-sided pain, more of that right-sided colitis. And then you have that fat wrapping, wall thickening, fissure, cobblestoning appearance, which is with fat wrapping which is quite typical of Crohn's disease. Next slide, please. I wonder if it's easier for me. There's quite a lot of interaction. I probably wonder if it's easier for me to do the changes. Are you happy to? Okay. So inflammatory bowel disease basically is managed. So it's lifelong, but you know the management. So you have management of the flares, the acute episodes, and then you try to get them into remission, and then you have drugs that you use to maintain. So you induce remission, and then you maintain remission. And basically, the drugs we use are steroids. I think I missed the really important one. So steroids. We also use diets, especially in children, to induce remission. we also use immunomodulators sometimes, but long term to maintain remission, that's to keep them in the stable phase where they're not actively inflamed. We use anti-inflammatory drugs and immunomodulators. And also there are complications from Crohn's, from both conditions, and then we get the surgeons involved. Next slide. So Crohn's disease, as you'd imagine, if 1% of the population is affected, a lot of people have mild Crohn, have mild IBD managed as outpatient. There's a good chunk. They tend to have increased to be in hospital more, so lots of morbidity, the complications, the studies that show reduced life expectancy. There are also complications such as we all hear the toxic metacolon, which is quite life-threatening. They can have perforations, strictures, fissures. There's also risk of infections, there's risk of cancer, which we now know, and unfortunately some of the treatments that we use for IBD exacerbate some of these complications like infection, risk of cancer, yes. And even the steroids we give, very commonly give, as we all know, steroids have all the side effects, like affects your blood pressure, your sugar, your bones, and all of that. So IBD generally is associated with quite a significant morbidity especially. I think here generally people don't tend to die quite easily from the complications, but then it's worth knowing that they tend to be in hospital for very long, prolonged admissions, repeated admissions, and all the drugs and complications. Next slide, please. So we'll go a bit to the pathophysiology, which I think is really important in understanding how diets work, the role of diets as in both a cause and a cure. Crohn's disease really, like I said initially, is idiopathic, so we don't really know why it occurs, but I'll walk you through some of the hypotheses. Basically, it's always been regarded as a disease of the West, like I said, but now there's rising incidence. When you look at a lot of the data, it says there's Africa, they don't have data from Africa, but now we're starting to have data from Africa. But what is clear is that there's a rising incidence in non-Western countries. And we don't really know why it's caused, but what we know is that there's a genetic susceptibility, there's differences and issues or changes in the gut microbiome, there's dysregulation of the immune system, and there's also lots of environmental factors. For example, there's been talk of childhood antibiotics, vaccination. I'm not saying that you should vaccinate your children. That's still the single most important intervention that humans invented. So, but there's talk about vaccination, there's smoking, there's breastfeeding, the role of breastfeeding, and smoking as well. Next, please. And so, people do wonder, does IBD result from because there's a dysregulated immune system? Because what we know about IBD is that your body is attacking your healthy gut cells and then causing the inflammation. So is it because your body has got an abnormal response, your immune system is responding abnormally, or is it because your gut lining and your gut mucosa is abnormal, the microbiome is deranged, and is that why your body is then attacking the gut cells of the gut? Next, please. But then the evidence suggests that it's actually an interplay of both. And then next, please. Next slide. So looking at this, so you can see it's not one or the other. In people who've got IBD, they're known to because we know that it's in certain countries, and when you look at all the environmental factors, the differences, the various things that impact on the gut microbiome is quite different in the areas, and I'm going to show you all of that in a bit. But then it's a complex interplay of the microbiome, the genetics of the individual, because sometimes it runs in families, and sometimes you have, especially in young children, where you have young onset IBD, and sometimes there are also conditions like congenital immunodeficiency syndromes, where they would manifest as IBD. Those are really different entities. But then you have IBD tends to run in families. You have environmental effects, like I said earlier, and then you also have the effects of infection. Like I did mention, we're seeing a lot of IBD now there was, when COVID just came, there was I haven't worked in gastro in a bit, and I'm going to start in September all over. But when I worked there, just after or during the middle of the COVID pandemic, there was quite a significant increase in IBD, and I've seen a lot of quite a few kids coming with really severe IBD, known to be completely well, had COVID, and 2 weeks later they came in a massive crisis. One needed her colon out in her, that was her presentation. So there's all of those things, infection, and even the food we eat, the food that is fed to the food we eat, the antibiotics we give to animals, the grass-fed cows, and all of those really impact what we, how our body responds to food. Next, please. So looking at the role of diet in IBD. Next. So as you can see, this is the only study. It's a BMJ article. All the references are in the slides. Unfortunately, you can't see them, and I can give them to you if you'd like them. So this is the only study that I could see. It's a recent 2019 study, I believe, or 2020 publication that had some data on Africa. Everything else puts a blank on Africa because there's no data. So you can see that it's really a disease of North America, Europe, and then you have some of it coming up in Australia. And then you can see really low levels in South America, in Africa, most of Africa except North Africa, which is starting to also rise. You can look at Asia, who's kind of getting towards the Western rates, even though Western rates are still the highest. But then you also wonder about the quality of data that's coming, let's say, from Africa. Are we diagnosing it enough? Do we have the diagnostic tools and all of that? Next slide, please. And so there's a lot of studies that are coming up now. Like, if you look at those, can you please go back to that, the last slide? So if you look at it, you wonder, the obvious thing is, what is the difference? It's certainly there's climate, and that's the thing about ecological studies. But then the diet is significantly different in both environments. The West generally is characterized by high omega-6 diet, high fat, high animal protein, highly processed foods, and lots of food additives, which is not usually the case in the developing countries. And there's lots of hypotheses that all those things are implicated in the development of IBD. Next, please. So then there's lots of studies, and unfortunately, nutritional epidemiology is one of the most difficult things to do, because it's difficult to do trials in humans. If I gave you a diet and said stick to this diet for 1 week, how easy is it going to be? And then if you tell people to have a diet for a year, 5 years, so it's extremely difficult. And often you have to use evidential data, so ask people to recall data. So you have to use historical data for studies, and you're asking people to recall things from 5-10 years back to then use in your data. How much bias are you introducing to all of that? But that's how those are the challenges for nutritional epidemiology. So, but I looked at this. The studies all say different things. I thought this one was particularly interesting because it kind of picked up on both. So it's a study from Stockholm. It was not much bigger. It was kind of an okay sample size, and their findings kind of mimicked a lot from the other studies, kind of put together. So basically, they looked at a number of patients, a few hundred patients with Crohn's disease and with IBD, so Crohn's and UC, and then had case controls, and then got population case controls. These were patients who had been hospitalized at some point, and then asked them to recall what they had been eating prior to the onset of IBD, and that's things from like more than 5 years back. And they found that there was a strong risk of IBD, or a high risk of IBD in those who were consuming processed sugars, animal proteins, and there was a slightly lower risk of IBD in those who had high fiber diets. But then there's lots of bias, like I said, because if you're poorly with IBD, you're probably more likely to think, yeah, maybe I ate poorly and that's why I've developed IBD. So, like I said, kind of tricky. But then next slide, this systematic review then combines lots of data. It's really the biggest systematic review that I could find on this topic. So it kind of looks at the evidence all together. It looks at 19 studies. and with quite a large population size. So more than 2,600 patients, almost half and half of IBD and Crohn's, and then also looked at 4,000 population control. And then it looks at it looks at those that had looked at similar to those the case control study I mentioned earlier, and it concluded that patients who had high dietary fats, high polyunsaturated fatty acids, high omega-6 fatty acids in the diet. I was hoping the Kel would be here to listen because there was a bit about microbiome and omega fatty acids and micronutrients, which I thought would be interesting from his follow-up talk. And also lots of meat, especially animal proteins, which were associated with higher risk of both IBD, of both Crohn's disease and ulcerative colitis. And they also thought that it's a much lower risk or association. So high fiber and food intake were associated with a decreased risk. I didn't want to bore you all with the figures. Next, please. But then it leads us to the question, what is the role of food? Why are we seeing these massive differences or changes, these massive differences in clinical outcome? Why is IBD more common in these areas? Because of the food. What is food doing to our body? And I think the gut is one of those organs that I'm really fascinated about. I think the gut controls a lot about us. If you don't, there's all about the gut-brain barrier. There's a lot about the microbiome. The microbiome determines a lot about the state of your gut health. It determines a lot, and your gut health, which the role of the gut in terms of homeostasis, it's got hormonal role, it's got nutrition. None of that really is electrolyte imbalance. Just a few, and a lot of that is really important in how your body functions. So if you have a poorly gut, then chances are if you're unable to absorb nutrients properly, for example, chances are your immune system won't function properly. It's just such a whole interesting cycle. So what is the microbiome? It's simply the term used to describe the bacteria that colonize the human gut, and I can't quote the figure, but there's quite a multitude, a vast range of organisms, microorganisms, various types of bacteria living in the human gut. And these are responsible for maintaining the gut, the health of the gut, like I said. There's so many factors that influence the gut microbiome. Like I said earlier, some of these, of all of these, diet really is one that's really been studied the most, and scientists say it's the most important. Next, please. So just to highlight the importance of the gut microbiome, there's the koala bear. So I don't know if you know the koala bear, probably. So the koala bear, when they give birth to their babies, if the babies, so there's a particular food that they eat that they need enzymes to digest. If the babies do not have some of the excreta from the mom, they are unable to digest the food that they eat. So that's just an example of how strongly the environment or the things we eat could affect the microbiome. And people think, in humans, it probably would be similar kind of situation. And in pediatrics as well, all these things are being explored in neonates, in necrotizing enterocolitis. Is there something we can do to prevent necrotizing enterocolitis? Are babies born by C-section, for example, who haven't eaten some of the mom's poop? Are they more likely to have NEC, for example? So the microbiome is really, really important. Can't overemphasize its importance. And it's important to have a good balance between the microbiome and the individual, and because it's really key to your development, like I said. Next slide, please. And scientists really think that the gut microbiome, the state of the gut microbiome, may be a really strong driver for the development of IBD. So then, it leads us to the question, what actually causes an altered gut microbiome or a deranged epithelial barrier? And like I said earlier, next, please, there are lots of environmental factors again, but diet has been well studied, and there are certain specific nutrients that have been found to really influence the gut microbiome. Like I said, in meat, the way meat is metabolized, it produces more sulfites. I think it's sulfites, which are more prone to cause inflammation. But I'll give examples. So vitamins, amino acids, short chain fatty acids, these are all things that have been shown to. So like I said, so meat contains sulfur amino acids, which when fermented by the gut bacteria produces the hydrogen sulfide, which then contributes to UC. And there's been quite good, which can affect the balance of the gut microbiome. Next, please. So you'll be wondering, what are the omega-3 and 6 fatty acids? I think we hear about them. They're all important, but it's important to have one, which is what you want to have. Next slide, please. So thinking about the potential mechanisms on the page, so we probably don't have a lot on that. But looking at the differences, how they affect the gut microbiome when they've looked at humans, and so when they've looked in animal models and also in humans, and all of this is important, like I said earlier, in the development of IBD. Yeah, next please. So looking again, studies, and others have just done retrospective cohorts, and there's been changes. So even like this particular study, which again the reference. So again, next slide please. So to treat IBD, but then so both to induce remission, and there's lots of studies to see how nutrition can be used to maintain remission. But how much time have I got, please? I wasn't watching. I could talk about this the whole day. In pediatrics, there's quite strong evidence on use of diets. I know in adults sometimes it's difficult because of compliance to diets and issues around palatability. But in peds, some of these treatments for IBD, yes, we have treatments that work, but then the side effects of the treatments necessitate the question, you know, can we have alternative treatments? And the role of nutrition is that one. So quite a few diets have been used in IBD, have been studied, sorry. And have to use GA, and, you know, all of that is all, you know, you wonder about the ethics and all of that. But then what we know is EEN. I'm sure we've all heard about EEN. That's the one established. We do have established treatments for that. But in ulcerative colitis, there are ongoing studies, but so far, not very much success. So just looking at the types of studies published on various IBD interventions. So I've spoken about you're avoiding those highly refined sugars. You have low FODMAP diets. Sorry, I don't know if we know much about FODMAP. Talk about it a little bit later. You have the Mediterranean diet. You have the so EEN, like I said, is the only established treatment for Crohn's disease, for pediatric Crohn's disease. It induces remission in about 80% of people, promotes gut just specially prepared formula feed. And then, so we give it either orally by NG tube, however the child is going to take it. And then, so next slide, please. The mechanism of action is unclear, but we think it downregulates the inflammatory cytokines and then helps to rebuild that gut with gut healing. And therapies are being developed. So diets that can be used to treat IBD, for example, there's a Crohn's disease treat diet which aims to mimic the EEN. There's the Crohn's disease exclusion diet as well. Researchers in Glasgow, it's I think really the UK, but mainly based in Glasgow. And the whole aim of it is using whole foods that mimic EEN. And the basic, I think when I first, they use fresh everything, so no canned stuff, fresh, no frozen meat either, meat killed straight from the farm to your plate. You could use dried and soaked pulses, but no canned stuff. And all gluten-free, lactose is 60%, even though up to 80% of participants were found to have some kind of clinical improvement. And they also looked at the inflammatory markers, calprotectin, serum markers, and these as well had comparable efficacy to EEN. And when you want to look at the benefits, so you think about, should I give steroids, should I give EEN, can I give food? And if steroids have these side effects and EEN is not very palatable, other researchers have tried the exclusion diet. So this one was an RCT done by some Israeli researchers in collaboration with European researchers, and they also looked at EEN. So it's not like an exclusive diet like the Crohn's disease treat. So here you have some E, and modeling is what we use most common. Who had presented in active disease, and then with this study, they used patients who had relapsed. Next slide, please. And so just an idea if improves or worsens. So the mandatory foods were fresh chicken breast. They gave some eggs. They all gave the quantities that they had to have. Certain types of fruits. They avoided they don't want to give loads of fiber because maybe they have diarrhea and you're going to worsen all of the gut motion. And then they also restricted. They had a group of foods that they restricted, and then there were foods that were completely disallowed, like any processed foods, dairy foods, animal fats, and only. Next slide, please. So, not going to bore you all. Again, the specific carbohydrate diet, the certain foods to avoid. It still focuses on the canned, frozen. If you can. Next slide, please. And then, so the Paleolithic diet, which people advocate for it as a diet that was consumed by our ancestors, and talk about eating all the cereal grains. There's some evidence that it helps in IBS, but they're also looking at it in IBD. And some IBD patients who do the gluten products that we know, it's a bit tricky because some of the things you think are healthy, are avoided in the low FODMAP diet. However, this tends to be a kind of a diagnostic thing, so it's not well studied. There's no good evidence that it really works. Next slide, please. And so, what does this mean for the future? Phase will never materialize into the population, but then there's quite a number of risks identified which are really strongly proven to be associated with Crohn's disease. And I use the word possibly recursion. They possibly play a role, and high fiber diet seems to be protective. However, and also with the increasing incidence of IBD, it does look additional studies. Next, please. We also know that certain diets are important, are good in treating Crohn's disease. Less evidence with ulcerative colitis, like I said, good tomorrow. Oh no, eggs are not very good. So tomorrow it could all change. Could you go back to that last slide, please? Yeah. And also there's the limitations of ecological studies. So we have to think about all the bias that it's subject to. Next, please. So next slide, please. I don't know what the right answer is. Phyllis can help, maybe Leke can help. There you go. Next slide, please. I wonder if you have any questions for me.
Thank you very much, Dr. Zo. I think that was really presented. I wonder though, just before you go, so one question from another chronic diseases, because they are stuck to the local diet. The richer ones are becoming more westernized, and they're getting, we saw that with COVID, didn't we? Now, have you found any study that looked at how people eat more of the canned foods and the rich one buy more of the organic foods? Have you found anything like that?
Yeah, that's true. I think ecological studies, but and also people in Africa, like I said, it's also about the food that we eat. Yeah. Conclusive about that, but it's something worth thinking about.
Yeah. Any questions for Dr. Nzo, please? I got the hand up there.
Thank you for
We'll see.
Well, while she's looking for the map, the country have more stress than I was comparing actually America, that was high prevalence, than Canada. And when you look at Canada, part of Canada weather, and their incidence was less than compared to the West. And I was thinking about that map. I was looking at all those developed countries, Japan and so on.
I couldn't talk about it. Where do you think people are more stressed? Do you think people are more stressed here or say in Africa?
Yes. Well, when you mentioned that you saw a lot of babies coming after COVID and so on. During the COVID, people would have more. GPs are here. The incidence of depression during post-COVID was those living in Africa. And you were talking about babies. You know, when you got the infection, that's high level of stress.
Mm-hmm.
And that's probably, I'm just thinking.
Yeah, you're right. That's a factor. And the developing countries. And yes, stress could be one of them. I'm not sure how much of it has been looked into.
I think
Unfortunately,
just to add to what Dr. Nzodo said, I think she did mention that it was, and as she emphasized that it was the other factors and give them the best food possible at the develop the disease. So yeah, I think that's one point to take home from today is the fact that it's a multifactorial disease. But of course, stress is very important.
okay.
I was just curious regarding the findings you shared for the comparative study between the CD treat and the EN, and the finding of 60%, like the isolated effects of the CD treat on the patients.
Yes.
I
So
was also curious, like zoom in and see if compliance was also controlled for in terms of like.
yes, so that 60% is the absolute rate of remission in that group, but then it was controlled compared to the EEN group.
In compliance because it's more since
Yes, they did account for compliance because those diets. So with EEN and the CD3, they're meant to exclusively be on that diet. So and they excluded people who.
Like you pacified a little bit when it was the FODMAP because I mean I'm really into the low FODMAPs, being a victim myself of IBD. I'm IBS, sorry. So is there like an overlap between both conditions?
Yes, there are scoring systems for both Crohn's and ulcerative colitis, which I didn't think would be necessary to get into. So, which would often be used in the acute phase to kind of, stenosing disease. So that's a bit too much detail and not quite relevant here. But yes, there are staging systems. IBD is really a disease of adults. I don't see it in children on its own. I'm not the best person to say again. And the way the literature says to use it is that it's not a long-term diet, but it's something that you use for a brief period, maybe 8 weeks, to exclude all of that and then reintroduce them one after the other to see which.
Which sounds a bit worse than that.
Yeah, so and the other question you asked is whether the pathophysiology is similar. I think a lot of to the gut microbiome, which is why it's really important to kind of maintain that balance.
Thank you so much.
You're welcome.
And just before I cut off to make the biosis in adults, we reduce the chance of developing chronic diseases. So when you visit Dr. Nafti's plate, it has a plate behind there. Look at it very well. There's a lot of things that tend to reduce this biosis. So I'll ask the
For example, I saw, we said westernized, that you saw in the north, look at Australia, which is, so yet it was in the highest of levels. Okay, so clearly the thing about the weather is not necessarily the case. We know you've emphasized very much that diet is also then develop more of the inflammatory bowel symptoms. Those are the sort of things. If you look in Latin America, big country data that shows prevalence in some of the races with respect to the others. Eating maybe different foods or eating the same things. When we then talk about stress, Nkwai was talking about stress. Hey, the stress is different because we suffer here with a lot of social stress. COVID showed economic status. So should we be having more inflammatory bowel disease than the other?
The straight answer to that is yes. And that particular study looked at immigrants. It was a prospective study that looked at immigrants who had arrived and then followed them after quite years later, which I didn't have time to present or talk about. That looked at the effects of the rates of IBD in those countries that had westernized and urbanized, and really, and the rates they were much higher compared to diabetes and hypertension and the metabolic syndrome. But one of the hallmarks of Crohn's disease is the wrapping or creeping fat in the so it's the visceral fat in the abdomen. In migrants, it would be the same for Crohn's disease because they kind of have the same kind of flares and triggers and all this pro-inflammatory diet. Overfed people have thought about that and getting more inflammation from that. It's also processes, but so yeah.
I think we had the last industry, then you will have very little food in the supermarket. So I'm sure that's one of the take-up points as well. Any further questions from?
I think this is a really good way to find out about our people and learn more, so we could help ourselves really. Because if we're waiting,
so much interest in the microbiome and its gut and its role in the gut health and the whole body system. There's a lot about the gut-brain interplay. I don't know how much.
Since then, diabetes has increased and lots of gut issues as well. So it's all about diversity. The more diverse your microbiome, the better your overall health is. And certain bacteria favor.
Am I supposed to remove this one?
New attendees,
He did very good.
Tea over there, so we're going to have a coffee break. But I'm going to ask one quiz before we go. One quiz. Can anybody tell me when coffee was first drunk? Which country first drank coffee? Now let's, I remember what I said. The two biggest killers are sitting down too much and lack of social connection. So get up, have a cup of coffee, and then work. Hi, again. The housekeeping, so for your punishment is the fire alarm, you stay in here. Anybody who wants to tell my mom what to do, put your phone on.
I tell you, sir.
Now, in as well, some diseases of the gut which are quite important for us to know and deal with. So I'll introduce Professor Theodore Ngachu, who is a professor of medicine and but you will know his work in gastroenterology and also in trying to introduce a lot of gastroenterological practice in Cameroon. So, Dr. Ngachu, thank you very much. I'll let you have the floor.
In CAMDOC, I get so emotional. And I think I'll have to came to Europe when I was 18 years old. Okay, and I've been in Europe for 40 years. And when I came, my ambition was to go back to Cameroon. So, yes, welcome. She is. So, when, you know, in those days in Italy, when you are preparing your thesis, you decide where you want to go to prepare your thesis. So I thought, if I want to go back and work in Cameroon, what is the best specialty? Went into gastroenterology and did my thesis in gastroenterology, in hepatology, particularly in viral hepatitis. And I did in Cameroon. So I went to Cameroon to do my research in viral hepatitis. You know, so when I qualified, I'm ready to graduate. So can I leave her in Italy and go back to Cameroon? That sounds like a really, really long story.
Hepatitis B.
There are a lot of my contemporaries in Italy in the room as well, so they would know. So I thought I better go and specialize. So I went into specialization. It had a different twist, you know. And I've stayed in Europe all these years. And so now, I think they don't want to see Dad. All they want to know is, Dad, can you put the money? Yes, you know. So I can ease that. We have decided to put up a medical center in Cameroon. You know, now I'm plugging. I consider a state-of-the-art medicine. I don't think I will want to go back to Cameroon and offer something less than what care from a decent environment. I want to give you that same service in Cameroon. Now, my dream is that what we are doing in Cameroon, if you want to invest in the center, come and talk to me. Now, the woman I was talking about is currently in that center. And
Unmute yourself, Paul, and turn on your video.
Paul, can you unmute and turn your video on? in my presentation. So like I said, what I considered a specialty that would be of use to Cameroon and did my specialization. And today I've been called up to talk about common problems, common GI problems in adults. Now, whilst I was preparing for these different levels and different interests, so I will try to make the presentation simple and hopefully understand.
Just click.
Right. Do I need to put it on something? It is a continuous tube, okay, from the mouth to the anus. And in that tube, lots of things happen. Things come in, things reservoir, certain things start happening with digestion. So you heard Dr. Nzo talking about diet, digestion, diseases. So that diet gets in there. You start getting the bugs in detail. Any questions? So let's look at dyspepsia. That's one of the most common GI condition and in addition, okay? So any discomfort that you can attribute to that area, particularly after meal, is considered to be a dyspeptic symptom. Those abnormalities don't tend to coincide with the symptoms, okay? So they call them functional dyspepsia or non-ulcer dyspepsia, okay? The ulcer type dyspepsia, when I teach medical students, I tell them, if you take a good history, you probably hit 50% of your diagnosis. So if you take a good history, does food make it better or make it worse? It's very relevant, very important, okay? You want to know whether that particular symptom gets worse when they eat a particular. So they'll tell you if it makes them better, okay? The other thing you want to know from the history is whether they have any associated symptoms, okay? So do I just treat the patient or do I investigate the patient? And at times that can be a dilemma, okay? Particularly for those doctors in primary care, you know. One rule of thumb is if there is a role for the patient for investigation, don't treat the patient because you could be missing something more sinister, okay? Now, you see, if your investigations are no morning, they will get bloated in the evening before they go to bed. Now, people are listening very attentively. I want to make this a funny part of it, but it's serious. All inhibitions go away, okay? All inhibitions go away, and the air comes out easily. Will help, okay? In the upper digestive tract, it's not farting. Okay. Now, in some people, that sphincter is wide patent. Okay. And if it is widely patent, stuff comes up easily. So they get acid reflux. So is this one? Okay. Barrett's esophagus is supposed to protect the esophagus from acid, from gastric content, but also is a precursor to esophageal cancer, okay? So if you see Barrett's esophagus in an endoscopy non-acid, tells me if the symptoms correlate with any reflux. So it's actually much more sensitive to know that that is the problem. Symptoms of peptic ulcer disease is epigastric pain, okay? Now, I use these two questions. They say people with gastric ulcer lose weight. People with duodenal ulcers gain weight. But now, it's very worrying, okay? Because somebody with gastric ulcer who is losing, very rarely duodenal ulcers are malignant. Duodenal ulcers are commonly associated with Helicobacter pylori to the point where some consultants don't even test for it, for Helicobacter pylori. They find a duodenal ulcer, they eradicate. Melena, okay? Melena is very important. I have one of my colleagues who has a go at all our junior doctors because stale blood can look black. If you are in doubt, get the blood on a white piece of paper. Okay? Melina will still be black on the white piece of paper. When I was a registrar, it's always a good argument with the surgical registrar. Oh, this patient has got blood PR. I need a gastro. How old is the patient? 40 years old. Good. Okay. And what is the blood pressure? Normal blood pressure. It can happen. I say, okay. When I was at St. Mary's, in London, we were manning the GI bleed team. The consultants didn't even pitch up.
Theo, can I just make one caveat?
Yes.
So again, as a house officer, I witnessed a patient with an ulcer.
It was on the previous slide, the last bit.
Yes.
Large volume bleed.
Yes. Yes, that's true. Yes.
But then they wouldn't have
Now,
HB of 12.
you got peptic ulcer as top, no cause identified. Okay. Then varices is only 11%, but you look at that. Varices, esophagitis, gastritis, malorivice. Yes.
So Theo, what's the reason?
Sorry?
What's the reason why portal hypertension
In Cameroon. In Cameroon.
are so high?
Now, it's not a very difficult thing. So if you look at diagnostic endoscopy in those patients, okay, so that's my endoscope there. It ends somewhere there, okay, doesn't go beyond. I'll identify 95% of the bleeding. Therapeutic endoscopy, that is therapeutic endoscopy. That is not diagnostic, okay? If you put the scope down and you see the bleeding and you treat it, yes. I was really, really disappointed sitting in an interview panel for a consultant and the right place. So, oh, sorry. This is an interesting slide. I went to Nigeria to teach. What they did was people with GI bleed come to the hospital, okay, and while they are consenting the patient, they ask the patient, if I see something that is bleeding, pay the difference, you know. Now, look at the outcome. Look at the outcome. Out of 36, those who had treatment, only 2 died. Out of 16, those who had no treatment, 8 of them died after 6 months. Yeah? Look at duodenal ulcers. Look at look at that. Look at that. Yes. Mamimo, that is what I asked myself. I said, how can an ethics committee approve that? But it's very relevant. It's very relevant. You know, that is very relevant. And you can see how many people will die.
Because it's true that it's all money. But if they just put the cost of the endoscopy and treatment all together, that would take away the fact that they have to pay more.
50,000 francs CFA at La Cathedral. Believe me, I will not even get out of my bed in England to go and do an endoscopy for 50,000 francs. Yes, it's a very big issue and it's a different topic of discussion which I don't want to get into. Can we get the next slide, please? So how do we decide? these are some signs. I thought I better bring these ones, which are actually in black people. Okay. Can anyone about leukonychia? What's relevant about leukonychia? Leukonychia is actually a sign of low albumin. It's a sign of long-term low albumin. Okay. So it's not unique to patients with liver disease. So even patients. So these are some of the causes that you would find in history. Okay, either the person is consuming too much alcohol or the patient. Now, hemochromatosis is accumulation of iron. Okay, now there is a difference between iron overload and hemochromatosis. Patients with iron overload don't get liver disease. Steatotic liver disease. Yes, you know, and I watched a YouTube program. The bottom line is this: liver diseases, they go through these stages. Okay, so it starts with fatty liver. Okay, most of these conditions will cause fatty liver. And it, next slide, please.
Before you continue, Theo,
sorry,
because we're talking about fatty liver, it's something that we in primary care we see a lot. Should we be following them up?
Pathologists, there will be no space to see them. Okay, so the UK medical community wants to see only those patients with fatty liver disease who, now, if the patient comes to secondary care anyway, that is what they will do. They will check and see there's a risk of fibrosis. And if there's a risk of fibrosis, they will keep following up. If not, they will refer the patient back to primary care.
What about fibrosis?
Hasn't got varices. And if the patient has varices, you have to treat them. Okay. And that is another debate. Do you ban the varices that have been validated to assess liver fibrosis? Yes. There are other methods that can tell you about liver fibrosis. You can get an MRI, and the longer these things stay, you get fibrosis, and if they carry on, they will get liver cirrhosis. And when they get patients with viral hepatitis. Yes.
So
but
even cirrhosis is reversible?
Yes. Giving time enough and get back to a normal liver. Okay. So that is my last slide, and thank you very much for listening.
Thank you. I'd like to say that. Can I just take one or two questions for Prof, and then we can move to the next speaker? Yes, JC.
Yeah, thank you so much, Prof, for the presentation. Really wonderful revision that can be used to treat resistant Helicobacter.
Right. Do you want me to give you a political answer or a clinical answer? Both answers. That basic environment that stimulates the G cells, that produces gastrin, that stimulates acid production. Okay. So what you want to do, you want to get rid of the Helicobacter ulcers can come with. Okay. Now, the current treatment is a triple therapy. So 2 antibiotics and a proton pump inhibition. Now, if you've done 2 antibiotics and a proton pump inhibition, increased eradication. The political answer is we in Cameroon, we try to pick up what is actually supposed to be for the West money. Helicobacter pylori is so common. People will have reinfection because the condition is so common in the population. Okay. So do you want to spend the small money you have?
Minister signed a paper with your name on it recently.
What paper?
We're talking about creating the office for the diaspora.
About what happened in Cameroon, I will do my question in English, but I try to do my best because I'm not often.
You want to talk in French?
No. In English, we are in UK. I have to diagnosis Helicobacter pylori during doing serology. This is it's something quite So some take antigen in the stool. Cool. We have, I think, to teach our colleagues even after school, because there are some. I think, and the last thing was about bleeding. It's really strange. It's really strange, but in emergency room, when somebody
Right. Okay. Now,
it was just my because I'm working in Cameroon, so this is only what I.
so if it is your first time and the serology positive, then you can be reassured to offer eradication. You cannot use Helicobacter pylori serology to confirm eradication. Okay. Talking about adrenaline orally, I think you know, okay. If somebody is bleeding from the upper GI tract, the most common place that bleeding is going to come from is the duodenum or the stomach. So drinking that cocktail is unlikely. Pump inhibition reduces bleeding. Okay, so it's best you give the patient the proton pump inhibition. Give it intravenous if you want to. If you give a proton pump inhibition to a bleeding patient.
Right, thank you. Thank you very much, Prof. Gachu. We're going to have our next speaker, who will be Dr. Eugenie.
Okay, will you be?
Can we have Dr. Eugenie? Sit down.
Which was published in the Journal of Laryngology. This is the customized vestibular rehabilitation. With the shout. I'll just shout, yeah. Our local clinical effectiveness unit. I was saying that the triple PD is a new term, but the disease is not. This background observation in the photoneurologic setting, then they define photoneurologic setting, then they define the term as phobic postural disease. And when they observe a lot of patients from status, end up with some visual and vestibular mismatch, and then over rely on the vision for the balance, then not coping in any situation where there is any week for at least 3 months. Here, the persistent symptom can occur with provocation or without, but they are exacerbated, accounted for any other vestibular disorder. The pathophysiology is still not well understood, but it's believed that it's involved, and then the score will be the total sum divided by the number of situations minus the number never tried. Any SCQ over 0.9, dim potom, and also the psychological intervention or counseling or CBT, because it's a functional disease. Okay. And then I will come back to our team with the situational questionnaire over 0.9. Patients were seen in our clinic between 2017 and 2008, and they attend at least 2 follow-ups. Okay, what is the virtual reality? We started using it in 2017. You can see that it's a 3D dimension of the patient using the Google, which is linked to a substitution of the vestibular system to help them to be able to cope in this situation, different environment where they can stay without feeling dizzy. Questionnaire for the hyperventilation. We then compare the pre and post vestibular rehabilitation and the in clinic twice, 3 times, until 6 times, but we couldn't consider the 6th time because we only have 1 patient. But the good news was that patient recovered, but with 1 patient we couldn't do any analysis, emotional and functional. Unfortunately, we didn't have a really significant, statistically significant improvement with the incorporating the virtual reality-based therapy with the physical or vestibular therapy in even non-randomized study, but it was difficult to differentiate how many exercises patient really had, then and which exercise don't see their value. Thank you.
Thank you very much. Thank you very much.
To do it once a week, and we move to the Oculus, which is more real setting, because patient with computer were seated and then they can do it standing and one walking. But now with the Oculus.
Any questions? I'll do one question from Inquiry.
Thank you for the presentation. Just you know the questionnaire that you had at the beginning that you said this was what
the situational characteristic questionnaire.
Is it something that could be used in primary care?
To follow up your rehabilitation to see how patient is moving.
Do you have to be trained to use that gadget, or something will be fine? Because for me, it looks
Thank you very much. Thank you very much, Dr. Menko. Can I have your seat? Now there is, so can I introduce Professor Maurice Sutebo, who's come all the way from the UAE. Advisor to the sepsis chair in the UK, and then went to UAE, and he wrote a book called From Struggles to Success. I'm sure you can tell us more about that.
Joy, as Professor Theo said, it makes your heart, warms your heart to see how much CAMDOC UK has developed since we left it, since I left it for 4 years. Linda and Kojo for continuing with and everybody for continuing the hard work. So as Val said, I am Emmanuel Sutebo. I am an infectious disease consultant and also work in Khalifa University as an adjunct professor for infectious diseases. But I'm going to talk to you about a bit about sepsis. So there is some medical bit about it, but it's mainly about society in the UAE as vice president in spare time. So hopefully you'll see the link with what I'm going to say in a minute. So again, I'm going to talk to you about struggles and struggles to success. And you've seen the advert on the CAMDOC UK group. When you feel that you can't overcome, something serious has happened. And I'm sure you've all been there. And you've all been there, part of life, isn't it? Emerge from that dark moment in life that happens always to something that is stronger and better for you and for people around you, whether it's to success. But I will let you read the book in detail, but I'll describe it to you in summary. And it always, and I need to always take a breath whenever before I did. I was a close friend. Her partner to be, my best friend, indeed, lived 5 minutes from us. And Delphine was admitted to hospital, got engaged, IVF, babies, twins, boys coming, learned how to drive, bought a car, bought a house. It was one of those moments when you pinch yourself and say, to the hospital for a cervical string, just to stop the babies from delivering the babies early. Simple procedure. And I went to work, saw her the night before. When you hear crash call, maternity ward, you all know it's a young person, probably pregnant. So it's not somebody in their 80s or maybe has an infection. And after the crash team came, I said, I know her. And I apologized, and he said it was okay for me to step out. Delphine had developed sepsis in a maternity ward in hospital, seen by midwife, seen by a doctor when I, as a junior doctor at that point. What do you do? And I still vividly remember Martin, Delphine's partner at this time, looking at me and saying, and we used to call each other the Pa. So he said, training, became a consultant in infectious diseases, and I moved to Liverpool. And Liverpool, great job. One of the biggest infectious disease centers in the UK. Brilliant team. And then he was discharged, sent back a letter to the medical director, to the clinician, saying, why are you not recognizing sepsis? Why are you not training the doctors, the nurses to recognize sepsis? Why are you naughty? You didn't recognize sepsis. You must do it. Nothing has changed because that's not what brings about change. And we decided, and within a year, mortality of sepsis started coming down. We were receiving thank you letters from patients saying, I came to the hospital, this is what happened, they saved my life. And so we went to national work. And then from there, with the Global Sepsis Line, got involved in the Global Sepsis Line. And started doing a lot of work internationally with the Global Sepsis Line, which I still do now. Still undertaken by infection. Africa has the highest burden disease sepsis in the world. 35% of cases of sepsis, highest mortality, the least amount of work. So why sepsis research in Africa, and then 8 million also from the German government just last year. So there's a lot of research, a lot of funding has come through, a lot of education. You can make the most of it. You can actually merge better, stronger, and more successful. And after going through the journey of there, same issue. I did a big hospital, tertiary hospital. I was a single ID physician. I arrived thinking I was going to an infectious disease team, going to run the phone, doesn't ring. But again, that is about turning things around. The other example is COVID. You all recognize COVID. After a hospital, we brought all of us in the hospital very close together. We developed a system now we would not have done before without COVID. So we made the most of COVID. And even as an infectious disease unit, we're really strong now. When you've gone through the journey and you've seen people do it, and I've coached some people and watched people do it, there is a method in it. And it's like a skill. The more you do it, you become solving, you become a better problem solver. When there's a crisis, you run towards a crisis, you don't run away from a crisis. So you become a better problem solver. You also use it to innovate. You find bigger because solve a bigger problem. So it's part of leadership. But if you do it well and develop the skill, you also become better, stronger, more successful. A lot of details, but it's quite just 5 minutes. Yes, it's quite simple.
No, sorry, not even 5. Sorry, we might have to continue afterwards. The lunch is ready,
right.
And if
you do buy the book, write a review, please. And I look forward also to sharing your own struggles. We've got a podcast or interview.
I already brought my own. I brought my own book.
We're safe here with the laptops, aren't we?
Yeah, I'm going to go and find out if we can get a card for it.
Okay.
But I want you guys to.
1, 2, 1, 2.